Hey all, thanks for listening. Welcome back to the Real Life Pharmacology podcast. I'm your host, Eric Christensen, pharmacist, and we have got a heavy hitter for a drug today, a drug called carbamazepine, and there is a ton of clinical pearls with this medication. So we'll just get right into it. Brand name of this medication is Tegretol, and its mechanism isn't totally well understood, and there's multiple possible mechanisms. I would say the one that's most commonly associated with the use of this drug is it binds sodium channels and alters sodium transfer across cell membranes, which can ultimately slow down, prevent action potentials from happening and synapses and things like that. So kind of a little bit more of a challenging medication as far as the mechanism goes, because there is kind of so much ambiguity, and it works in the brain, which makes things more difficult to research and understand. But that sodium channel aspect does seem to be important. Other things that it can potentially cause can stimulate the release of ADH, so we'll talk about that a little bit in the adverse effect profile. Mildly anticholinergic as well. I would say in the grand scheme of things that probably isn't a huge deal, but because there are so many different side effects and boxed warnings with this medication. Now, getting into the uses, in my clinical practice, probably the three most common I've seen Tegretol or carbamazepine used for is seizures, bipolar disorder, and trigeminal neuralgia. And it's really a messy drug as far as lots of drug interactions, which I'll cover. So that's really why you don't see a lot of providers using this medication, because there's so much monitoring and potential for hazards along the way with this medication. But obviously in a situation like seizures, bipolar disorder, or trigeminal neuralgia, where maybe we're limited in options and or it's a very serious condition, you may potentially see it. I did want to mention target concentrations. Usual target concentrations are 4 to 12 micrograms per mil. Now, with that said, in something like epilepsy, this is much more important to find kind of that target goal level of where we want a patient to be. In something like trigeminal neuralgia, where you're treating pain and you're treating symptoms, obviously it's probably not that big a deal to find a target concentrations. Now, if you're recognizing some symptoms of toxicity, maybe some CNS problems, some GI upset, things of that nature, that might be a situation where you actually check a level. But in trigeminal neuralgia, for example, ongoing routine monitoring of levels is going to be much less important than when you're treating seizures with this medication. One thing that always comes up or frequently comes up on exams is carbamazepine is an enzyme inducer, and it can actually auto-induce its own metabolism. So it kind of stimulates itself, stimulates the breakdown of itself until it reaches a steady state. But this autoinduction can take weeks, maybe in the period of 2 to 5 weeks for this autoinduction kind of to come to a steady state. So if you've got a patient that's maybe very stable after a few days or a week or something like that, there is potential that those concentrations could come down as kind of this autoinduction ramps up a little bit. So what that means, if a patient is starting on this medication and we're doing drug levels and monitoring for efficacy, whether it's reducing seizures or mood control with bipolar disorder, we need to have that close monitoring within those maybe first 1 to 2 months, that type of thing. Now, adverse effects, we've got boxed warnings with carbamazepine. And so the first one's actually a genetic variation. So patients with the allele HLA-B1502, and I have seen that come up on test questions as well, these patients are at risk for a severe skin reaction called Stevens-Johnson syndrome. So that's a good one to remember. Also warnings on aplastic anemia, also agranulocytosis. So lots of things to kind of unpack. And you could definitely understand how, monitoring certain labs, CBC and things of that nature would be important with this medication. Now, toxicity, I did want to talk about a little bit. So obviously these, box warning things can happen, but in the realm of toxicity due to too high of concentrations, I think you can think of it very similarly to, alcohol, phenytoin, those kind of toxicities where you're really going to have, that CNS depression, maybe dizziness, maybe ataxia, difficulty walking, maybe nausea and vomiting, some GI upset, confusion, things of that nature is what you're going to see if those drug levels get elevated. Now, a couple other adverse effects. Again, I said this was a very dirty drug. I always think about hyponatremia. I absolutely have seen cases of SIADH and hyponatremia from carbamazepine. That risk tends to go up as we're on more agents that can also cause hyponatremia. You think about, loop diuretics or diuretics in general. I also think about SSRIs and medications of that nature as well. So definitely important to keep tabs on sodium with this medication. Liver toxicity is possible. LFTs are in with that CBC monitoring as well as the sodium monitoring, an important aspect that you're going to want to follow. And along, with the LFTs that I mentioned, you got to think about other agents that might be damaging to the liver as well. Obviously, in combination with another agent like carbamazepine, that can cause some liver problems. That's something to certainly be aware of as you're looking at that patient's maybe polypharmacy medication list. So with that, let's take a quick break from our sponsor. Meded101.com/store is a proud sponsor of the Real Life Pharmacology podcast. If you love the podcast, enjoy the free material, go support meded101.com/store. Tons of resources. You can even get a couple free ones if you've never had an Audible book. So definitely go check out those links. Take advantage of that. If you're a pharmacist or a pharmacy student looking for board certification materials, absolutely that is a good place to go check out what we've got at meded101.com/store. Drug interactions. So probably the biggest thing I think of with carbamazepine is it is an inducer, and you always got to remember what an inducer is versus what an inhibitor is. So a CYP3A4 inducer is going to stimulate these enzymes in the liver to clear the body of drug or metabolize drugs more quickly. So if a drug, not carbamazepine, is metabolized by CYP3A4 and we use carbamazepine, that drug is going to basically be chewed up faster, and its effects aren't going to last as long in a patient who is not on carbamazepine. So that's kind of a simple, as simple as I can make it, explanation to try to understand what happens to these drugs that go through CYP3A4. And here's some examples. So apixaban and rivaroxaban, also warfarin, so anticoagulants. So if those concentrations fall because we're using carbamazepine, that's a pretty big concern. Depending upon what you're using it for, you're looking at increased risk of DVT, PE, potentially a risk of stroke if we don't have adequate anticoagulant concentrations to help prevent those strokes. So definitely a big deal there. Again, great example why we try to steer clear from using carbamazepine if we can avoid it. Aripiprazole, olanzapine, a couple of antipsychotics I think of. There's anti-HIV drugs. So I think of the protease inhibitors as well as some other oddballs that can be reduced concentrations and reduce the effectiveness there ultimately. Diltiazem, verapamil, again, a couple of medications. You may see them used for hypertension, may see them used for maybe migraine prevention, maybe atrial fibrillation, a few different uses you can use that type of class for. Again, those concentrations could be reduced by adding carbamazepine. Some of the azole antifungals you got to think about. Contraception, so estrogen contraception could be chewed up a little bit quicker, and that might leave a patient at more risk for becoming pregnant when maybe they don't necessarily want to be. So that's an important one there as well. Also some other oddballs, hydrocodone, that's got some CYP3A4 metabolic breakdown. Tadalafil, another example, with the phosphodiesterase 5 inhibitors there, a drug for erectile dysfunction. So very, very important to think about other drugs whenever carbamazepine. I think that's the bluntest, most simple point I can tell you. And I would encourage you, if you see this drug being used, to run an interactions check, look it up, and see what we're going to be affecting. Because if you've got a patient on 3, 4, or 5 plus medications and carbamazepine, odds are probably pretty favorable that one of them might be affected. So very, very important there. Couple of things I did want to mention. So grapefruit juice, so that is known to be a CYP3A4 inhibitor. So this can actually raise concentrations of carbamazepine. So grapefruit juice with carbamazepine may put a patient at risk for carbamazepine toxicity. Important to remember that one. I do want to, I kind of hinted at the LFTs, thinking about drugs that may cause liver function problems, and you add on carbamazepine, could be potentially an additive effect type of thing. And then I also think of the SIADH, which I think I mentioned a couple examples there of other drugs that could cause that adverse effect and that low sodium as well. So that's going to wrap it up for today. Thanks for listening. If you love the podcast, found it helpful, leave us a rating, review on iTunes. Greatly, greatly appreciated, or wherever else you're listening there. Get your free top 200 study guides, 31-page PDF, reallifepharmacology.com. That's simply for subscribing. You'll get that, and you'll basically get email blasts as to when we have a new educational podcast is what that list is for there. So support our sponsor, meded101.com/store, and I am going to sign off for today. Thanks for listening, and have a good rest of your day.